Welcome back to Decode Healthcare. I'm Harshal, and today we're jumping right into a masterclass explainer on the absolute must-know guidelines for coding critical care services. If you've been working with CPT codes 99291 and 99292, you already know they are heavily scrutinized. So we're going to break down the dense CPT manual rules, dissect those specific time thresholds, and really lock in the documentation requirements so you can code these complex, high-stakes encounters with total confidence.
Here's our syllabus to conquer these guidelines: defining critical care, time rules, the under 30-minute rule, countable versus non-countable time, bundled services, and finally, modifiers and concurrent care. Let's jump right in.
All right, Section 1, Defining Critical Care.
Before we even look at the clock and start tracking minutes, we really need to understand what makes a patient truly critical according to the manual. The CPT defines this as the direct delivery of medical care for a critically ill or injured patient where vital organ system failure creates a high probability of imminent or life-threatening deterioration. So the crucial point here is that this requires high-complexity decision-making to assess, manipulate, and support vital system functions. We're talking central nervous system failure, circulatory failure, shock, or respiratory failure. It is intense, direct medical management.
I really want to emphasize this specific phrase: a high probability of imminent or life-threatening deterioration. This is quite literally the linchpin of medical necessity here. If there is no immediate threat to life or bodily function, well, it's simply not critical care. And here is a massive misconception we need to clear up right now. Just because a patient happens to be physically located in a critical care unit, like a CCU or an ICU, doesn't automatically mean you can build critical care codes. The patient's actual condition and the treatment being provided are what dictate the code, not the room number.
Moving on to Section 2, Critical Care Time Rules.
Now that we've established the clinical medical necessity, let's see how this builds into some pretty strict time tracking. Because critical care is entirely time-based, knowing the CPT manual's exact thresholds is absolutely your best defense against an audit. Critical care time is the total time spent by the physician evaluating, treating, and managing that critically ill patient on a given date. And hey, that time doesn't even have to be continuous. You just tally up the total minutes for that single calendar day.
Think of it kind of like a base fare plus mileage on a taxi ride. You use base code 99291 for the first 30 to 74 minutes of care on a given date. This base code can only be reported once per day. Then, the add-on code 99292 kicks in for each additional 30-minute block beyond that initial 74 minutes. So, for example, if the total time is between 75 and 104 minutes, you code 99291 plus 1 unit of 99292. If it stretches from 105 to 134 minutes, you report 99291 plus 2 units of 99292, and so on.
Section 3, the under 30-minute rule.
Listen closely here, because this is a golden rule in medical coding. You absolutely must hit a minimum of 30 total minutes to report critical care. If you don't hit 30, you just don't have a critical care claim.
But you might be wondering, what happens if the doc spends a highly complex yet slightly shorter amount of time stabilizing the patient? Well, the CPT guidelines are incredibly clear on this fallback protocol. If you have, say, 29 minutes of highly intense, life-saving critical care, you cannot bill 99291. It doesn't matter how complex the intervention was. If the total time for the day is under 30 minutes, you've got to fall back to selecting the appropriate standard evaluation and management code based on time or medical decision-making for that setting.
Okay, Section 4, Countable versus Non-Countable Time. To accurately calculate those vital 30 minutes, we need to draw a hard line. Every minute matters, sure, but not every minute counts. You can count time spent at the immediate bedside, obviously. But you can also count time spent on the floor or unit reviewing test results, discussing the patient's care with other medical staff, and even documenting the care in the medical record. However, non-countable time includes any activities outside the unit or off the floor. Taking a phone call from home or the office about the patient doesn't count, because the physician isn't immediately available to the patient. Teaching unrelated to that specific patient doesn't count either. And time spent performing separately reportable procedures is entirely excluded from your tally.
Which brings up a highly practical question. Often in these critical scenarios, the patient is intubated, unconscious, or just otherwise lacks capacity to communicate. So, how does time spent speaking with their family factor into all this?
The CPT guidelines actually have a very specific carve-out for this. Time spent on the floor or unit discussing treatment, Obtaining a medical history, reviewing prognosis, or discussing limitations of treatment with family members or surrogate decision-makers is fully countable, but only under two strict conditions. First, the patient must lack capacity to participate in the discussion themselves. Second, the conversation must bear directly on the medical management of the patient. If those criteria are met, you can confidently count that time towards their total.
Section 5. Bundled Critical Care Services.
Moving right along, you also need to be extremely careful not to double dip when billing. Because of the high valuation of these codes, certain services are considered bundled and cannot be reported separately. This includes things like the interpretation of cardiac output measurements, chest x-rays, pulse oximetry, blood gases, gastric intubation, temporary transcutaneous pacing, ventilator management, and various vascular access procedures. If the same provider is billing 99291, they cannot separately bill for managing the ventilator or reading that stat chest x-ray. It's basically an all-inclusive package for those specific bundled codes. But any services performed that are not on this specific CPT manual list, those should absolutely be reported separately.
And finally, Section 6, Modifiers and Concurrent Care.
To wrap up this explainer, we need to address two special coding scenarios that honestly trip coders up all the time. First up, critical care is often a massive team effort. If multiple physicians from entirely different specialties provide distinct critical care to the same patient on the same day, both can actually report their respective critical care time using 99291 and 99292. The keywords here are different specialty and distinct care. They've got to be managing different aspects of the vital organ system failure, and their time cannot overlap. They must be tracking their own individual time spent directly managing the patient.
Now, what if a provider performs a standard hospital visit in the morning, and then the patient abruptly crashes in the afternoon requiring critical care? Well, you can report critical care and other EM services provided to the same patient on the same date by the same individual. However, the standard EM service must be significantly, separately identifiable from the critical care interventions, and you'll need to slap modifier 25 onto that standard EM code to show it was truly distinct. And remember, time spent providing the standard EM service cannot be counted toward the critical care time.
So, we've covered the strict definitions, the rigid time thresholds, the countable activities, and the bundled services that define critical care coding. As you apply these CPT guidelines to ensure compliance and accurate reimbursement, I really want you to ask yourself how mastering these details will transform your next facility audit. Getting this right protects your providers and ensures the massive effort of life-saving care is properly documented. Thanks for watching, and don't forget to like, share, and subscribe to Decode Healthcare with Harshal.